Good morning, everyone. I thank the organizer of the conference and all the audience. I am Professor Iannetti. I come from Rome, Italy, University La Sapienza, and the topic of my speech is management of functional constipation. So we start from the chronic constipation and from the definition, the classification, the diagnosis, and the therapy. Well, the definition can be, I want to report this old definition. In 1965, Connell, in British Medical Journal, talked that the 99% of healthy subjects in United Kingdom had evacuations between 3 a week and 3 a day. So this is the normality, and for definition since that time. And only 1/3 of the subjects who have constipation complain of infrequent evacuation, but the most people complains of difficult evacuation, as Sander and Rosman told in Digestive Disease and Science in 1987. But another definition can be this definition. Excuse me. Another definition is this one, very simple, is a fecal passage through colon and rectum, slow and or difficult, like it is in this study in Canadian Journal of Gastroenterology. And another definition, a more recent definition, is from American College of Gastroenterology Task Force. And this is very similar to the up-to-date definition that we are going to see now. And I talk about the road to Roma criteria, very important group of experts who studied the management of the functional digestive diseases. And the road to Rome criteria go to Roma 3 in 2006, and the most recent Rome 4. And you can see that the definitions are very similar. And in the Rome 4 group of study, the functional gastrointestinal disorders are catalogized in that way, and you can see that in bowel disorder we have irritable bowel syndrome and functional constipation. So the criteria for functional constipation in Rome 4 classification in 2016, this is the definition. That the chronic and functional constipation must include 2 or more of the following: lumpy or hard stool, straining in more than 25% of defecation, sensation of anorectal obstruction blockage, sensation of incomplete evacuation, manual maneuvers to facilitate, and fewer than 3 spontaneous bowel movements for a week. More, you must have loose stool, very rare, and not present without laxatives, and if you have insufficient criteria for irritable bowel syndrome, IBS. Note that criteria fulfilled for the last 3 months with symptoms onset at least 6 months prior to diagnosis. And note that abdominal pain and or bloating can be present but are not predominant. So this support the concept that functional constipation and IBS with constipation component are disorders that exist in a continuous spectrum but must be different. considered as different pathologies. And we see that chronic constipation, from the point of view of patient, is especially pointed on the difficult evacuation, not on the frequency of the evacuation. And it is the very famous, the very important Bristol stool chart, because it's very important to talk with the patient about the type of the stools. And now we go to the diagnostic path and two different diagnoses, differential diagnosis between secondary and idiopathic constipation. We see that the secondary constipation may be secondary to mechanic, surgical, or endocrine, metabolic, or myopathic, or neurological, or pharmacological, or other etiology, and we can resume this etiology. The mechanical, surgical very often mean rectal or colon cancer, or extraintestinal masses, or diverticulitis, or stenosis after diverticulitis, or post-anastomotic. Endocrine and metabolic class are very often diabetes, hypothyroidism, electrolytes disorders, chronic renal insufficiency. We must remember the connective pathologies like amyloidosis and sclerodermia, and neuropathies like ictus, cerebrospinal cord disease, sclerosis. And we must remember that many drugs are potentially cause of chronic constipation. We have medical prescription drugs like opiates, sympathicomimetics, anti-Parkinson, tricyclic antidepressants, antipsychotics, calcium antagonists, antispasmodics, and some self-prescription like antidiarrheals, antacid, anticholinergic, antispastic, antihistaminic, martial therapy. And we talk now about idiopathic constipation. We talk about alteration of intrinsic mechanism responsible for controlling gastrointestinal and anorectal function. And this is the main possibilities that we have. We can have an alteration of colic transit time, or an alteration of expulsive performance. And we have the examination to study these two different etiopathogens causes. So this is, for example, the study of the transit time only with radiopac pellets after 96 hours, that means 4 days. And we see that we can have the colon constipation, slow transit, because the pellets are in all the colon, or we can have the pellet in the left colon, and we have a problem of expulsive constipation. And this is the explication. You see inertia coli, where the transit is low, or we have, transit slowed down distally, and so we have isolated disorder of defecation, probably expulsive constipation, or normal transit, so there is no constipation. And we have to remember the anorectal anatomy, of course all of us remember very well, and remember that anorectal function must control the continence and the evacuation. And I have to remember that anorectal manometry is a very important physiopathological investigation. So remember that anorectal junction in the course on the evacuation is very important, because we have the rectal filling and the rectal detent, because very important, all the apparatus must detent the stools if we cannot go to the bathroom, and the internal ernestellar sphincters go to relax when the anorectal angle increase, and we have the passage of fecal contents that we can see in this diagram. We have the squeeze when we don't want to defecate, rest when we begin to defecation, and the evacuation. So this diagram shows the manometric graphic, and making the manometric examination, it's very important the test of ball expulsions that you see is only a seat, and you have to test if the patient can expulse a balloon of latex filled with water. And go back to the diagram, and we can have, so if colonic transit times and expulsive tests that we have shown before are normal, there is no constipation. It can be IBC like irritable bowel syndrome at constipation with constipation component. If we have normal test expulsion but delay of colonic transit time, we have slow transit constipation or inertia coli. So we can try to measure the human colon motor activity, and we have segmenting activity and, especially important, propagated activity with low amplitude contraction, and especially important, propagated contraction of high amplitude, and we have mass movements. And we can see that frequency and amplitude of the high pressure propagated contractions are very different in controls and in constipation people. So we can ask ourselves if motility change in constipation are limited in the colon or also in the small intestine. So some studies about the small intestine activity show that there are abnormalities, and we can see this is a normal a manometer in an healthy subject, and we see an abnormal activity in intestinal neuropathy. We have to remember that control mechanism of gastrointestinal motility must be referred to central nervous system that communicates with the enteric nervous system by intestinal cells of chylus, hormones, smooth muscle, and also immune system. And go back to the flow chart that we showed before, because we can have a distal delay of colon transit time and altered expulsive tests, and then we have expulsive constipation. And we can talk about two principal kind of expulsive constipation: anismus and descending perineum syndrome. Anismus, you can see that is especially paradoxical anal contraction, and so I show you this manometry, anorectal manometry, and this is the anorectal manometry in rapport related to the anorectal angle accentuation, and contraction of internal anal sphincter. When you have both of these, this is an anismus because there is no a good correlation between relaxation of the muscle of the sphincter and the accentuation of the anorectal angle. Now talk about descending perineum syndrome, and we have the diagram that show how the muscles of the pelvic floor go down, especially during the defecatory act. And we can show this by a X-ray defecography, and we see the diagram of the imaging of the rest, contraction, and relaxation and defecation. And there is some abnormalities like rectocele. And we go to the last chance, that is delay of colonic transit time and also altered expulsive test. This is a form of mixed constipation. Mixed constipation, we have slow transit and more expulsion. We have concomitant disorders, expulsive sticks favored by evacuation attempts in the absence of stool in the rectal floors. So there is a worsening of the problem. And now I show you the clinical assessment and exclusion of and the flowchart, the diagnostic flowchart. First of all, we have to make a clinical assessment and exclude curable causes of constipation, like allergies, intestinal infection, and other problems. After that, we can perform a therapeutical trials, giving to our patients fiber, laxative, appropriate water intake, dietary modification. So we have first level specialistic test. After that, if that doesn't work, we have to perform first level specialistic test. And we have the gastroenterological, proctological, gastroenterological visit and perform colonoscopy. After that, we have to perform the test of colonic transit time, CTT, and after that, the anorectal manometry, and with ballon eject test. And this is the flowchart. If slow transit, so we must test also the small intestine by CT scan, contrast ultrasonography, SICUS, or enterography, magnetic resonance. If this is not, that can be normal, so it means that we have only isolated colon slowing, or maybe IBS, irritable bowel syndrome, or a small, light case of inertia colon. But if it is abnormal, this means that we have a diffuse motor disorders, IBS, or pseudointestinal chronic obstruction. If we have normal transit time, it can be a technical error, or it can be an IBS or psychological disorders. And then if we perform expulsion constipation, if we see that is a ballon eject test anomaly, and this is expulsion constipation, we have to perform a defecography or defeco MR resonance magnetic to detect pelvic floor dysfunction or anatomical alteration. This is very important, this diagram. And now go to the chronic constipation therapy, the last topic of the presentation. And we can start from non-pharmacological therapy, because many patients mistakenly believe that daily evacuation is a must. But in some patients, it may be necessary to have a daily diary to determine the nature of the disturbances in frequency of evacuation, intensity, and if it is present effort, and the duration of the effort. So, it is necessary to consider the possibility that constipation is induced by medication, as I told before. So we have to eliminate the potential harmful drug, and this may improve the constipation. More, some tips about a lifestyle may be useful, like a regular intestinal habit can be at least partly conditioned. It has been shown that the majority of subjects with normal alvo have a circadian rhythm of almost stable evacuation. So patients should be encouraged to evacuate on awakening when intestinal motility is more pronounced, or 30 minutes after meals, when we have the gastrocolonic reflex. But they have not to stress themselves in trying to defecate. But we have to emphasize that it is very important not to suppress the evacuation stimulus. Inhibition of stimulus and evacuation may result in stagnation and further dehydration of the stools, with later greater difficulty in expulsion. And we have this study that shows that stimulation or repression is a malicious event. Now talk about the food and fibers. So it's believed that in Western population an inadequate fiber supply is commonly associated with constipation. Is it true or is it false? Well, it is interesting to note that there is few studies aimed at assessing the role of dietary fiber in subjects with chronic constipation. There are no differences in controls. The transit time are usually prolonged and the fecal volume is generally reduced in the constipated subject compared to the control, regardless to the supply of dietary fibers. So, constipated patients exhibited reduced fecal weight and slow transit even if they assumed more than 20 grams of brain per day. So, if constipated patient assume much brain, maybe they don't ameliorate their constipation. So, although a high fiber content can increase fecal weight in constipated subjects, the results obtained will, in any case, remain lower than the standard. And for this reason, the result of a high fiber diet may be disappointing in constipated patients. Some patients may benefit from fibers, but in many cases with severe constipation, fibers can lead to worsening symptoms, especially with bloating and aerophagia and abdominal pain or discomfort. And especially the effect of fibers is much less satisfactory in patients with slow transit constipation. So, patients with a fiber-rich diet is modest due to side effects such as flatulence, meteorism, and abdominal distension. And to improve compliance, it's much better to increase the dose of fibers gradually, maybe 5 grams per week. And how long time food fibers in constipation? The benefits are observed not before than 4 or 5 days. And in conclusion, it is useful to recommend a fiber supplement in the constipated patients with an excessive refined diet, but the fiber should not be given indiscriminately or aggressively, and it is necessary to evaluate the subject tolerability and not modify how to submerge the fiber. And now talk about the liquid intake. proper hydration is important to modulate intestinal motility. However, despite the opinion that the lack of liquids could increase the risk of constipation, studies did not make any significant evidence that fluid intake could affect the frequency and the consistency of stools. So we have a transverse study, and we have the water intake in constipated subjects and colon is superimposable. In fact, in healthy volunteers, a relatively short period of time dehydration reduces the frequency and the volume of the stools. There is no evidence, however, that an increase of contribution of liquid within tolerated limits, of course, can improve a chronic constipation. And we have this important study in gastroenterology in 1990. And the hydration reduced the frequency and the weight of the stools, but not the transit time. And enhanced water intake up to 2 liters per day does not increase the fecal output. So a proper water intake can improve the constipation. In conclusion, we can say that available data suggest that fecal output cannot be significantly altered by fluid ingestion. There is also no evidence that constipation can be enhanced by increased mouth fluids, except that in dehydrated patients. And we remember that endogenous secretion contribute to the liquid 2 liters in dietary intake, endogenous secretion. More we have, this is in liquid intake. Endogenous secretion are about 7 liters a day. So we have the small intestine absorption 7 liters, the colon and the rectum absorption 1.9 liters, so we have only 0.1 liter defecation. So, proper water supply can improve constipation? It is unlikely. The answer is not surprising when the small intestine is able to absorb from 7 to 10 liters per day. And so we can conclude that an increase in fluid supply can improve urinary flow but not fecal volume. An important water supply can be useful, but rarely it is necessary. And we talk about the physical activity. We are always talking about non-pharmacological therapy for constipation. We have data confirming and data oppositing. The National Health and Nutrition Examination Survey has shown that poor physical activity doubles the risk of constipation. But opposite data in this study, we see that the risk of constipation in adults is independent from physical activity. And with a stable dietary intake, physical activity does not affect colic function. In conclusion, physical activity can affect bowel function, but it is certainly not the prominent factor in constipation. The relationship between physical activity and constipation seems to be more evident in the elderly, although other factors seems to play a predominant role, like diet, drugs, cognitive disorders. So the take-home message about the physical activity is, although it is good to encourage patients to exercise regularly whenever possible, there is no significant evidence of an important role in physical activity in relieving constipation. We just to say that there are often the indication or the probability that some other alternative therapies may play a role in the therapy of constipation, because often patients affected by constipation show a very bad quality of life, and so also cognitive and psychological problems. And now go to the pharmacological therapy of constipation. The main objectives are modify the stool consistency and modify the intestinal transit. We see that stool consistency we have in the physiological alvo the content of water in feces is from 75 to 80%, in bacterial and food residues 70%, and the water dilution is from 5 to 10%. But in constipation we have water dilution 0%. And we remember the bidirectional brain-gut interaction. Now I remember that we are talking about functional disorders, and functional disorders means an altered interaction between the central nervous system and the enteric nervous system. And we can see all the mediators of the signals that go from enteric area, enteric system, nervous system, to the central nervous system. And the classification of laxatives, this is a first classification, but this is a more updated classification, and talk about bulking of hydrophilic agents like fiber, psyllium, methylcellulose, osmotic agents like poorly absorbed disaccharides and polyethylene glycol, very important. Stimulant laxative like diphenylmethane, castor oils and anthracinones, lubrificant agent, and neuromuscular agents that are the last drugs. And we talk about bulking or hydrophilic agents, and we talk about dietary fiber, psyllium, polycarbophilic, methylcellulose. And the osmotic agents like magnesium sulfate, magnesium hydroxide citrate, sodium sulfate, potassium sodium tartrate, and the poorly absorbed disaccharides like lactuloses, sorbitol, and polyethylene glycol. And the mode of action of lactulose and macrogol are very similar because they are mode of action is the no reabsorption and because the action is to keep water in the lumen, but macrogol binds a definite amount of water, and lactulose makes the same but have a problem of metabolization and forms gas. This is the non-digestible sugars. The mode of action of lactulose you see, and they have bacterial fermentative breakdown in the colon, and so we have production of carbon dioxide gas, and they cause the disturbance of meteorism and flatulence. But the osmotic mechanism is very similar to the polyethylene glycol. And this is the molecular structure of the polyethylene glycol. And we can see in this slide that pharmacological therapy of constipation by disaccharides and PEG is very similar, but the main difference is that both of them call water for osmosis, with osmotic mechanism, but the disaccharides are metabolized and cause methionine and choline distension, while polyethylene glycol does not produce meteorism. And we see the change in stool consistency during PEG intake, which you see that the water is, the stool are very less consistency. And very important, in this study, you see the correlation between daily stool weight and especially of mean residence time. And you can see, if you, in this study, who make a confront between the lactulose and PEG, you can see that MRT, that is mean residence time in colon, is much better for PEG than for lactulose. You see that PEG, the medium mean residence time in colon, is much less than lactulose. And in this prospective randomized parallel group trial to evaluate the effects of lactulose and PEGs, we have these results. In conclusion, that both lactulose and PEG are efficacious and well tolerated. However, PEG produces signs of decreased colonic fermentation in the stool, and so has better outcome, and especially has better outcome in mean residence time of stool in the colon. About stimulant laxative, there are surface active agents like docusaids and diphenylmethano and phenolphthalein, bisacodile, ricinoleic acid, and anthracinones, which is the action, the mode of action of a stimulant laxative. They stimulate the mesenteric plexus, and this is determines the inhibition of reabsorption, stimulation of propulsive concentration by way of promotion of transmission to the mesenteric plexus, and increase in secretion of chlorum and water. But the very important thing, you can see that efficacy of bisacodile in the acute treatment of constipation is very good, but you can see that they go to tachyphylaxis. We have to remember the mineral oil that have a lubricating action, but the most recent drugs are neuromuscular agent, and in particular the 5-HT4 agonists, serotonin agonists. And of these, you see that tecaserol and cisapride are no more available because of problem in the heart rate. And now we have prucalopride and a new agent that is not a serotonin agonist, but cyclase C guanylate receptor agonist, and his name is linaclotide. And this is slides that show the characteristics of the measured laxatives, but I don't talk about every of this. And you see the daily dose and some notes. And I want to talk about the side effects of laxatives that are in some cases very important. You see about bulking and hydrophilic agents. You can have bloating, flatulence, asthma in some cases because of allergic psyllium. In the case of mineral oil, you can have anal leakage and decrease of absorption of fat-soluble vitamins. And in the osmotic agents, you can have dehydration, bloating, congestive heart failure in some cases. And side effects of secretagogues and agents with direct effect on the epithelial nerve or smooth muscle cells. You have cramps, renal failure, protein loss enteropathy, Stevens-Johnson syndrome in some cases. And this is useful to have a look of the principal advantage and disadvantage of every type of laxative. You see bulk informing agents have long term, can be used long term, but you see the disadvantages are slow onset of action, mechanical obstruction risks, possible addiction, and you see for every type of laxative there are many disadvantages. But important to note that for polyethylene glycol there are very few disadvantages. And this is the dose for each agent, again the dose, and this is an important systematic review to undertake a systemic review of the efficacy and safety of traditional medical therapies for chronic constipation and to make evidence-based recommendation. The study examined the English literature from 1966 to 2003. And the conclusion is the PEG solution has the best good level of evidence and the best class of recommendation, grade A. And tecaserol 2. Tecaserol is no more available, and now we can have prucalopride, and now very last drug, the linaclotide. And psyllium and lactulose have a little worse level of evidence and class of recommendation. So good evidence, grade A, is found to support the use of PEG and tecaserol, and moderate evidence for psyllium and lactulose. And now just a few words for these new drugs that are prucalopride and linaclotide. Not so new, but linaclotide is the last one. It's important to remember that prucalopride acts as a selective high affinity serotonin receptor agonist, which targets the impaired motility associated with chronic constipation, thus normalizing bowel movements. And important to remember the selective high affinity serotonin 5-HT4 receptor agonist. So it has not the adverse event like the tecaserol and cisapride. And prucalopride can be safe and used for more than 24 months and has a few side effects such as headache and gastrointestinal symptoms. And there are a few contraindications. So, an Italian study over 873 reports that macrogol was the most prescribed laxative, and prucalopride and pelvic floor rehabilitation are the second line approach. And now linaclotide, as I told you before, is a different mechanism of action, is agonist of cyclinic guanylate C receptors with analgesic and secretory visceral activity. It increases fluid secretion and gastrointestinal motility and reduces visceral hypersensitivity. Is minimally absorbed, so there is no systemic drug-drug interaction. It's very important, and it gives no tachyphylaxis. This is the slides show the mechanism of action of linaclotide, and this is the miglioramenti. These are the meliorative effects on many symptoms like pain, constipation, and bloating and frequency of defecation. And this is the effect of linaclotide and or chronic constipation and on IBS with constipation component. And again, and more, the study over linaclotide, this document seeks to lay down a set of recommendations and to identify key issues that may be useful for the clinical management of EBS, IBS, C patients treated with linaclotide. I just want have a look on misaglifosine, a novel selective sodium glucose cotransporter 1 SGLT1 inhibitor for the amelioration of chronic constipation, but this is a new drug under investigation. And now I want to just spend a few words talking about surgical therapy of constipation. There are three types of surgical therapy. The surgery of pelvic malformation, the direct stimulation of sacral nerves, the neuromodulation, neurosacral modulation, and the surgery of the slow transit constipation. These are the pelvic disorders, the pelvic abnormalities susceptible of surgical correction. You can see lonely rectal ulcer, rectocele, especially cystocele, enterocele, peritoneum cele, pelvic floor dyskinesia, and the Hirschsprung disease. And this is the type of surgical intervention that can be performed, but only after having corrected the physiopathologic abnormalities that cause the anatomical abnormality. And this is the surgical intervention that can be performed. The transanal or perineal approach, we have the Delorme technique for the mucosectomy, the rectum sigmoidectomy, and the STAR, and we have the abdominal approach like the laparoscopic approach for posterior ectopesis and other types of surgical procedures. And a few words for sacral nerve neuromodulation, SNM. This is a procedure that begins for the treatment of urinary or fecal incontinence, urinary or fecal non-posterior retention, and chronic pelvic pain, but improves also in selected patients with constipation. And this is a few words about the techniques. It took place, and this procedure took place under general anesthesia with antibiotic prophylaxis, and we have to position an electrode in the space S3 in the colonna vertebral in this one, and after having positioned the stimulator, the electrode. We have to the needle must in the location of S3, and we have a period of test and decide on implantation of the permanent stimulator. Now talk about the surgical therapy of slow transit constipation. And we can say the patient with refractory colonic inertia are offered total abdominal colectomy and ileorectal anastomies, often in laparoscopic technique. And it is an effective surgical procedure, but it is crucial to inform the patient that the surgical procedure is aimed to ease the constipation, but it is not likely to alleviate other gastrointestinal symptoms. So, just remember what we know, that we have to exclude known causes of constipation, such as medication, low fiber diet, mechanical obstruction, etc. We have to confirm the diagnosis of severe functional colonic inertia by studying colonic transit time and radiographic marker, and exclude other possible treatment conditions such as disturbed defecation assessed by anorectal manometry, and defecation studies such as rectocele and rectal paralysis by imaging of pelvic floor, or chronic intestinal pseudostructure. After that, we can perform this operation, but only after an important and complete study of the patient. So I can conclude this report, this presentation, and I want to give some important take-home messages. It is very important a correct definition and classification of functional chronic constipation. It is important, remember, the main diagnostic investigation. It is important to recall the criteria of Roma 4, in particular the distinction between functional chronic constipation and irritable bowel syndrome with a constipation component. It is important, remember, that many therapeutic possibilities ranging from non-pharmacological life habits, type of nutrition, to all the laxative medicines on the market. In particular, we have to remember the latest high-performing pharmaceuticals that must be approached with skill and cognition, and the possibilities of a surgical approach, but this one must be carefully evaluated and framed in a multidisciplinary management. Thank you.